Hey everyone, happy spring. It's me, Mary Coughlin, the President and Chief Transformation Officer for Caring Essentials Collaborative, and I am back in action wanting to continue with my information about the core measures for age-appropriate care. So today, I thought I would just present the core measure for activities of daily living. The activities of daily living core measure embrace postural support, the eating experience of the infant in the hospital setting, and age-appropriate skin care routines and skin protective measures. So the postural support one, we used to call that positioning. And most recently, at the Science and Soul 2018 conference that we had in Bruges back in February, Dr. Heidelise Als was our keynote speaker for day 2. And she also participated in a lot of the group discussions and everything. And one of the discussions that was shared with me was her feelings about positioning. And I'm not sure if I've shared this with you before, but I thought it was really cool and insightful that she wasn't a big fan of the idea of positioning insofar as the ideal position for any infant, whether they're critically ill or not, is on the chest of their loving parent. And so positioning is almost kind of redundant, but the other insight from her comment that I thought was pretty cool was this idea that positioning the patient is a one-directional activity that doesn't really honor the shared experience of the care encounter. Are you getting what I mean? That I can reposition the patient, oh, it's time for a flip, we're going to do this. But really, my goal as a clinician practicing trauma-informed care and providing age-appropriate care is to assess the patient's need for postural support to optimize their alignment, to optimize their physiologic stability and their comfort. And so I really liked that the comment, and it really gives you pause to re-examine what is it that we are doing in the clinical setting versus being and being with. I think they're subtle words, these prepositions, but they really convey a lot of meaning and a lot of intention about the encounter that we're about to have with our patient. So there's, the postural support bit. And age-appropriate eating experiences. So of course, I'm taking this concept and I'm just going to push it right to the limit. We refer to these eating experiences traditionally as feeding. I'm feeding the baby. I'm feeding the patient. We talk about breastfeeding. But when I'm feeding the patient, again, the experience is that one-dimensional, one-directional type of activity where I am doing to the patient to accomplish my goals about whatever the feeding expectation is, the feeding expectation, versus an eating experience is completely different, right? The eating experience is from the patient's perspective, from the infant's perspective, and even with the parent. The eating dimensions I think that needs to really start cropping up in our day-to-day jargon in the NICU or PICU, because it isn't about us feeding, because you know what, I'm bigger, stronger, and I've got some, really amazing wrist action that I can feed you until the cows come home. Whether or not you eat and enjoy the experience is a whole different kettle of fish. And so age-appropriate eating experiences really need to revolve around the patient, obviously. They need to be nurturing, individualized, and to coin the work of Sue Ludwig and Carrie Ann Weitzman, infant-driven. And they need to be stress-free. I'm just going to move this over to make sure. Yep, I said that. Pain and stress-free. Because we know, based on our most recent outcomes, that infants that are fed, and they are fed with a volume focus, once they become volitional eaters, they are no longer interested in having anything into their mouth, because when a feeding instrument is placed into the mouth, it's very scary for these individuals. It's frightening. It threatens their airway patency. And I think from a nursing perspective, when I was a baby nurse, I never even paid attention to it. I thought if I can empty the bottle, and obviously the patient's still alive, check. But really, we have too much information now to continue that practice. And so making sure that they're nurturing has to be key. And certainly breast milk and breastfeeding should be the actively recommended and preferred diet for these infants. And I understand parent choice, and I don't want to shame anybody, you know, and you hear all of this jargon in the community about this. And I think we as an industry, healthcare industry, and certainly when we're caring for mothers and infants, really need to do our due diligence about educating moms about the importance of breastfeeding and the challenges with formula. I mean, at the end of the day, it absolutely should be their choice. Certainly, I do support the literature that recommends if the mother doesn't wish to breastfeed, could she pump her milk so that we can at least provide particularly the very small and fragile infants with breast milk, because we know of all the benefits associated with that, and we know that these infants are at increased risk for some significant pathology, specifically necrotizing enterocolitis, when they don't have a full breast milk diet. But again, you know, all of these core measure sets are comprised of evidence-based practices, and it is incumbent on us to be aware of what these are, and they are always evolving. There's a dynamic nature to evidence-based practice, right? Because people are always doing research, God bless them, and informing us with better information. Skin-to-skin care, I have that pretty much all over the core measures, but certainly in here, it should be aggressively encouraged, and pre-feeding activities should be supported. There was this really beautiful Facebook post about a breastfeeding diet, and the infant was like 28 weeks. And there was actually a paper that talked about when we do support skin-to-skin at these early gestational ages, and we allow the infant to explore the landscape and work on these pre-feeding activities of licking, sniffing, and that sort of thing, these individuals are more likely to be successful breastfeeders, which is the goal. That's the best practice, the better practice. And then the third criteria, is bottle feeding encounters. They should not be introduced any sooner than 34 weeks. This is well established in the literature. Anything sooner than that really can be threatening to the infant, and that infant readiness behaviors need to guide not only the initiation of the feeding encounter, but the ongoing eating encounter, right? See, it's still a new word for me too. That, you know, the quality of the eating experience needs to be assessed continuously, that you can't just plunk the bottle in and just start chatting with the team. It really requires that level of engagement, interaction, and assessment as well. Gauging how much external stimulation can the infant tolerate during this really challenging encounter. And then the last attribute is around age-appropriate skincare routines and skin protective measures that preserve barrier function and tissue. And I'm going to mention kangaroo care because certainly that proximity and the skin contact and everything does foster ongoing growth and development of a healthy microbiome for the infant. Also, what are our bathing habits? Are we bathing just because it's Tuesday, night shift in NICU B, or is there a real thoughtful process to this? I know that there's, you know, this big movement to eradicate, and it's the right thing to do, right? CLABSIs, hospital-acquired infections, but I think we need to strike a balance between the use of these antiseptic bathing solutions and maybe fostering a more stable microbiome with the infant that would possibly ward against hospital-acquired infections. These, you know, what I'm suggesting right now, these things absolutely do need to be investigated, but I don't think we just kind of throw the baby out with the bathwater, no pun intended, and say, well, we're just going to do this because that's what we do and that's our best practice. We haven't had any hospital-acquired infections. Well, is it too true and related, or is there actually a connection? Skin and mucous membranes need to be assessed routinely using a validated, reliable, and age-appropriate tool. And they also need to be protected from secondary injury. So when you talk about injuries associated with transepidural water losses and perturbations to the surface microbe, also injuries from the removal of tape and that sort of thing, we need to investigate effective trauma-informed and age-appropriate strategies to reduce injury, to do no harm, and support healthy growth and development of these individuals. So I know that's a lot, so this is probably one of my longest ones now. I'm getting more comfortable in front of the screen with you guys. But please throw your comments and your feedback down below as I share these core measures with you guys. I'll be back on the camera tomorrow, and tomorrow we'll talk about protected sleep. All right? Well, in the meantime, guys, as always, take care and care well. Bye.